think so. Yeah.
Good morning, ladies and gentlemen. Our presenter this morning is Dr. Teruschka Chetty. She qualified as a dermatologist in 2015 at the University of Victoria. Since then, she's been working in the private laboratory sector. She's currently an associate of healthcare and the hematology discipline coordinator for the same area. Her special interests are molecular hematology, coagulation, and laboratory quality. She is involved in quality assessments of external molecular labs. Thank you so much.
Good morning, everyone. Thank you for the opportunity. I just want to start quickly because we are a bit late on this very day. I just want to tell you about a few cases that you can see on the screen. The first one is Mary Reeser, 67 years old. She died in 1951 in the USA. Margaret Hogan, 89 years old. She died in 1970 in Dublin. And the rest, as you can read. And they all have the same suspected or proposed cause of death. I just want to know if anyone wants to venture against them. Everyone. Anyone? Yeah. Okay, so the proposed cause of death for all of these people, keeping in mind the last one is 2010, which was not so long. Was spontaneous human combustion. So a lot of them have been debunked, the theories on those cases and how they died. One was the wick effect hypothesis, where it just means like a subcutaneous tissue provides fuel for the fire, and like the wick, it just keeps burning. And that coupled with low mobility, advanced age, obesity, poor health, comorbid conditions, basically prevents the person from escaping the flames of fire. Another theory is that people in ketosis, like alcoholics and things, produce acetone as part of the ketones, and this is sort of highly flammable. So I think maybe if you're on keto diet, just stay away a bit far from the fire. And then another theory is that people who inhale phosphorus, it gets broken down into something called phosphine, which is also quite inflammable. And then alternative hypotheses, obviously nothing is proven, things called pyrotrons, and of course, this one, which is so all of these are basically being debunked, except for the last death in 2010, where the coroner officially signed off that death as spontaneous combustion. So I want to talk today about a condition called HLH, which is sort of really fire that burns within. HLH stands for hemophagocytic lymphohistiocytosis. So it's quite a mouthful, so obviously we prefer to use the abbreviation. So it is a rare and life-threatening syndrome or condition. It is basically marked by severe immune dysregulation. It results in a hyperinflammatory response, which in turn results in end organ damage and then death ultimately. It has a 1-year survival of about 56%, which, I mean, those odds are quite low. So it is quite a severe condition and important to know what it's about. And so it is, as I said, a severe hyperinflammatory syndrome. And it's characterized or described as hyperferritinemic. So these patients have very, very ferritins, which we'll discuss further. So what happens here is you have persistently activated cytotoxic T cells, which are your CD8 T cells, and NK cells, which are natural killer cells. These in turn cause activation of macrophages and histiocytes, and then you just have this excessive production of pro-inflammatory cytokines. In pediatrics, it's postulated to be the incidence of 1 to 225 per 300,000 live births, mean age of about 1.8 years. In adults, the mean age is a bit older, 50 years, males slightly more than females, and they say about 1 in 2,000 tertiary or ICU admissions will be complicated by HLH. You get different types. So the primary or familial HLH, this is the one found in children, and this is due to genetic mutations. They can be either homozygous, compound heterozygous, or X-linked. Basically, what happens is that spelling error here, but basically these mutations that you get, or variants that you get, fully eliminate the function of your cytotoxic T cells and NK cells, and usually these patients are diagnosed in the first year. These are just a list of all of the genetic abnormalities, so it's quite a lot. Currently, because it's so rare, we don't, it's not done in South Africa, but if you do have a patient, we can send it off to labs in the US and UK that have a panel for HIV, so it can be done. It's not recommended to do this in adult patients, just in your children. So, for more purposes, I suppose. Then you get secondary HLH, which is more now the one that's present in adults and more relevant to this discussion. And this is usually associated with external triggers. And these triggers can be infections, malignancies, most commonly, rheumatological diseases, or post-stem cell transplants. And there's an entity called macrophage activation syndrome. And that is basically HLH that has an autoimmune disease as the underlying trigger. Anyone with autoimmune, commonly things like SLE, those commonly associated with it. This table shows basically all the triggers. So malignancy is the most common trigger, and then hematological malignancies, even more common. So, and then it's usually firstly the T cell lymphomas, then B cells, then your other kinds of hematological malignancies. Less common is the solid organ malignancies. Then infections, also a huge trigger, mainly EBV and CMV, but also the other infections listed below, including brucella and things that fall under atypical infections. And then your inflammatory diseases or underlying rheumatological stories. So some of these are triggers, and some of these sort of mimic HLH. So are not treated in the same way, but presenting. So what happens with HLH? What is the pathophysiology here? So firstly, I just want to tell you about the normal response of the body to viral infections or tumor cells. This is just a very simplified response. As you know, immunology is quite complex. So basically, you have your CD8 T cells and natural killer cells, which release granules that contain things like granzymes and perforins. The function of the perforins is to create pores in your infected or tumor cell, and this results ultimately in osmotic lysis of that cell and then destruction. And it also facilitates the uptake of granzymes, which causes protein degradation of the cell, and then that cell undergoes apoptosis. Again, then destruction of the cell. So what happens here at the end of the day is that your antigenic stimulus is cleared because your infected or tumor cells are being destroyed, and the stimulus is removed, and then your immune response is eventually terminated. That is the normal way of things. Just a diagram to explain really the same thing. Okay, so what happens now in HLH? So in the familial one, you have basically the mutations which cause a loss of function of these T cells and NK cells. And then the antigenic stimulus cannot be cleared because those cells cannot be destroyed any longer. So what happens is your response is you get this inflammatory response, but you cannot stop it. So there's no feedback loop to stop that response. So it just goes in a loop, and it's basically an uncontrolled hypercytopenia. So during COVID, 2019 and 2020, that phrase of a cytokine storm was quite popularized, and I think your team will know very well about cytokine storms and how severe that inflammatory reaction is. So if you compare that as a cytokine storm to HLH is more of a cytokine inferno because it's an even more powerful inflammatory response than that. Just to put it in perspective for you. These are some of the pro-inflammatory cytokines that are released. There's a whole list. Interferon gamma is the main one, and then tumor necrosis factor alpha. There are other ones as well, it's listed below. But just to give you an idea, this is quite an inflammatory process going on here. Another diagram just to show again the different triggers and how it basically produces this inflammatory response. So basically, the bottom line is all of the processes result in this uncontrolled release of cytokines that is not stopped. There's no end to this reaction, and that is the problem. And it results in massive hemophagocytosis, which we'll talk about in further slides. Okay, so what is hemophagocytosis? It's basically this uncontrolled macrophage activity or histiocyte activity. And as you know, the function of that is to engulf other cells. Usually and normally, it's abnormal cells or virally infected cells or tumor cells. But here, in this process, it is now engulfing your mature cells. And how that happens is molecules like L-reticulin, which is a pro-phagocytic molecule, is upregulated now on cells as a response to this inflammatory process. And this tells your macrophages to basically engulf mature, normal blood cells. It's one of the ways. The second way is that the inflammatory response ends up with the downregulation CD47 on stem cells. And this basically is normally a protective mechanism, but because that's now downregulated, these cells become susceptible to hemophagocytosis. So you've got your normal developing cells that are downregulated, and then you've got your mature cells that are being eaten. So there are two ways now that your cell counts are being affected and dropping. So the pathogenesis of the secondary HLH, unfortunately, is not completely understood. And they postulate that in addition to the underlying triggers of malignancy or infection, as we mentioned, there also may be some kind of genetic mutation, maybe like single gene deletions or something like that in conjunction with the trigger, because not everybody with the trigger develops HLH. Again, resulting in the overproduction of pro-inflammatory cytokines. One of the theories also is that there's a sustained toll-like receptor activation, and that is the trigger for the immune response here. And then in your macrophage activation syndrome phenotype, so with the underlying autoimmune disorders, the theory here is that there's the overproduction of interleukin 18. This is important because these become targets for possible therapy. Again, just a highlight of all the triggers and how they are involved in producing this inflammatory response we've discussed. So the clinical features, the first one is unremitting fever. This is almost the most important, arguably the most important symptom. And they say that, if your patient does not have a fever, it's very unlikely that they've got this diagnosis. However, on the other side of the coin, to be aware of people who do not have a fever, because they might be on antipyretics that you put them on, they might be on antibiotics, and they also might be undergoing sort of cooling systems like on ECMO or dialysis, and then that sort of can mask the fever. So just beware of a person with no fever. The neurologic symptoms, splenomegaly, cytopenias, hyperferritinemia, elevated triglycerides, low fibrinogen, elevated liver enzymes. So some of these, as you can see, are not very specific. they are quite generalized symptoms. Other things like, hyperferritinemia and things are a little bit more suspicious. So how do you diagnose these patients? It is important because the mortality rate is so high and you want to get a diagnosis done by. So there is a society called the Hyperinflation and HLH Cross Speciality Collaboration Society, and they came up with guidelines in 2023, basically to raise awareness and reduce death from HLH. And one of the main things that they wanted to get out there is for people to have a high index of suspicion, because there's a diagnostic protocol, there's a treatment protocol and workup and everything, but who do you do these investigations on? So they postulated this 3 Fs that you need to look for in your patient for you to decide, let me work this patient up for HLH. And the 3 Fs stand for fever, falling blood counts or cytopenias, and then ferritin, raised ferritin. So if you've got these 3, then you can consider the work. This is how you work them up. Essentially, you do your 3 Fs and then you begin the workup. And then it's obviously the ferritin, FBC, fibrinogen, electrolytes, renal profile. So this is a lot of screening tests that you do on your critically ill patients anyway. So you might have access to this as well before you suspect an HLH. You might have access to these results. The other thing is to calculate the H scores, which I'll go through, and then importantly is to look for the underlying trigger through a specialized test. Do that. We'll cover that. So in 2004, so unfortunately, these studies are quite old. Nothing new has come up. So these are the diagnostic criteria that were proposed in 2004 by the Histiocyte Society, a very cool club. So they basically said you need 5 of 8 criteria, which is clinical and laboratory. I'll have a slide on what they are. The problem is that it was validated for pediatric patients. However, we still kind of use it for adult practice, but there are limitations. The other problem is that some of the tests on this criterion are quite specialized, so the results take some time to get out. So that is a bit of a problem. And then some of the features in adults of HLH that are usually always present, like deranged liver functions, are not included. So these are the criteria. So basically, you either need a molecular abnormality. Remember, this is for children. Or if you're looking at criterion 2, you need 5 of those 8. So it's fevers, splenomegaly, cytopenias. Usually you need 2 cytopenias and they have to be sufficiently severe. You need high triglycerides or low fibrinogen or both. You need hemophagocytosis in the marrow, low to no natural killer cell activity, high ferritin, high soluble CD25. That one is not easily available. And of course, your NK cell activity is not easily available. Others you can easily access. Just a note on hemophagocytosis, because it is in the name. It is suggestive of HLH, but its presence is not specific for HLH, and it is not even required for you to make the diagnosis. Sounds counterintuitive, but really isn't required. You can still make the diagnosis without seeing this feature involved. One of the reasons is that it can be cyclical, so that you miss it when you sample your bone marrow. And the other reason is erythrophagocytosis, so that means phagocytosis of your red cells, is quite common under certain circumstances like sepsis, blood transfusions, major surgeries, stem cell transplants, chemotherapy, and MDS. The thing to note with hemophagocytosis is that it's the only criterion that does not have a threshold. Like every other one will say, your HB needs to be less than 9, or AST has to be higher than a certain amount. There's no threshold for this. So there's a group of researchers, Haas et al., who did some studies and proposed the following. So you need one granulocyte out of 1,000 nucleated red cells for 6 of any type, etc. And if you have that, that's the minimum required for you to make. But remember, again, it's not necessary. This HLH probability score, or H-score, is actually more useful for adults. So it's a free online calculator. 9 variables are involved, 3 of them are clinical. So it's your underlying immunosuppression, presence of fever or organomegaly. 5 routine blood tests. So your ferritin, triglycerides, AST, fibrinogen, and cytopenias, or the FBC. And then 1 histopathological, which is the presence of hemophagocytosis, or other tissue for that matter. It's scored very differently. So the total score that you can get is 337, and then postulated a cutoff of 169. And that cutoff gives you a sensitivity of 93% and a specificity of 86%. Obviously, the higher your score above 169, the higher the sensitivity and specificity becomes. And this tool has been validated for adults, so it is more useful. Again, with the exception of the bone marrow, the other tests are not highly specialized, so you can get them in reasonable time. So these are just to give you an idea how the scoring is done. So for example, if there's underlying immunosuppression, you get 18 points. If there isn't, you get 0. So some things are scored very much higher than others. High ferritin, for example, is 50 points, high triglyceride 64. So the scoring is a bit difficult. I'm not really sure how they came up with it, but it is quite random. But you have an online calculator and you just punch in all of the things your patient has and it gives you the score. Just a little bit about some of the more important laboratory findings here. So unfortunately with HLH, there is no one single finding, including hemophagocytosis, that is pathognomonic of HLH. So it's a constellation of things that you need to put together to be able to make this diagnosis. So the cytopenias, the mechanism of that is your interferon gamma and tumor necrosis factor alpha, which is produced by your T helper 1 cells. They basically suppress normal bone marrow function, the formation of new cells, and they also induce apoptosis. So not only is your production reduced, but they're also dying off. So that's how you get to cytopenias. Your acute phase reactants from the hyperinflammatory state. Ferritin is the most common one that we measure, and it's part of your diagnostic criteria, etc. And this results from upregulation of heme oxygenase, which is a heat shock protein, and it's in response to inflammatory cytokines. The ferritin, so there have been lots of studies on how high this ferritin value should be, and if it's certainly value that is that more suggestive of HLH versus others. And the predictive value varies. So there isn't really a cutoff. They say it's not sensitive nor specific because there are other causes of very high ferritins, like liver injury, renal disease, severe sepsis, and hematological malignancies. However, they find it has a very good negative predictive value. So, if anything less than that, your patient is unlikely to have HLH. In terms of CD25, this is released. Soluble CD25 is basically released by your activated lymphocytes. So if this is increased, it's sort of a surrogate to say you've got an excessive activation of lymphocytes. And it is relatively specific. The problem is it's not a routine test, so it takes a bit of time to get the results. So one of the things they've postulated is if you have a high CD5 to ferritin ratio, that indicates or pushes you toward thinking that this trigger is a lymphoma-associated HLH. Please, it's not to diagnose lymphoma in other patients, so don't use it sort of as a surrogate to suspecting lymphoma in patients. It's patients with HLH. Differential diagnoses to consider. So the mainly is sepsis because a lot of the clinical features overlap. As we saw, both are characterized by hyperinflation. So it is important to distinguish between sepsis and HLH, mainly because in HLH, your goal is to suppress this immune response. Whereas if we do that with the patient in sepsis, that can be detrimental in some instances. Things that will help you distinguish the two. So the hyperferritin, the splenomegaly, low CRP, high cheeks, low fibrinogen in the absence of DIC, you would think HLH rather than sepsis. And then some of your atypical infections that can present looking like an HLH are those, and then an autoimmune disease called DRESS, which is basically a drug reaction with eosinophilia and systemic symptoms, and then viral encephalitis, multiple sclerosis, and acute necrotizing encephalopathy. They can all mask or mimic HLH. And then hematological disorders like Langerhans cell histiocytosis and multicentric Castleman's disease. So strangely enough, on Monday, I had this bone marrow case of a 47-year-old male patient who was admitted with an acute pancreatitis and alcohol-induced over the weekend. It led to multi-organ failure. He was on dialysis and intubated, and we had to do a marrow. He had an anemia at that point and thrombocytopenia, no history of fever or organomegaly confirmed radiologically. So we had an HB of 9.4, platelets of 38, and those were the abnormals on the LPC. White cell count was slightly raised. His ferritin was the highest I have ever seen. It was 191,600. I don't know, Agnes, if you've seen higher, but that's I have not. His BCT also extremely high, 630, also one of the higher ones that I've seen. Liver function, AST, very elevated, 4,690. Triglycerides, very elevated, 9.39. Fibrinogen was normal at 4.2. Did he have hemophagocytosis on the bone marrow? Yes, he did, and that's the picture of it on the side. That's a macrophage. It's not really clear. I apologize for that, but you can see platelets. You can see a neutrophil as well being within the macrophage cytoplasm. So I did the H score on him, and it was 160. And your cutoff was 160. So they are managing him with that. We have done the soluble CD25 because that will also help, but unfortunately that is now waiting for that. So he's quite ill, and so they are managing him. So yeah, I thought it was quite strange. This case came up on Monday when I was doing this patient. So the management, important to identify your underlying trigger and manage that. For example, if there's a viral infection, they respond very well if you treat that viral infection. In children, it's usually genetic. The most common cause in adults is underlying malignancy, and as I said, mostly heme malignancies. In fact, about 90% of them heme malignancies were solid tumors. And then for heme malignancies, there are actually three sort of settings within this category that you get. So one is if it presents together with the heme malignancy at the same time. That's a very poor survival of 10 to 20% at 5 years. The second is post-treatment. So IC, which is immune-compromised HLH. So after chemotherapy or post-stem cell transplant, they develop it in that phase. And the other is treatment-related. So especially with the CAR T cell therapy that we're using quite a lot of nowadays, they tend to get that treatment-related HLH. Then your infections, EBV, CMV, even COVID-19, the goal is to try and manage the underlying triggers. And then your macrophage activation syndrome with the underlying autoimmune disease. Important to pick this up, and I'll tell you why. So the HLH 2004 treatment protocol is still being used today, and the mainstay of that is chemotherapy in the form of etoposide, dexamethasone high dose, other immune suppression like cyclosporin, methotrexate, stem cell transplant eventually when you find a match, and then intrathecal steroids if there's neurological symptoms. So the reason for finding out about the underlying triggers is because in an autoimmune macrophage activation, you don't want to give the chemotherapy. The mainstay there is usually just the steroid therapy. There are new treatments now that's sort of targeted to what the cytokines are. So there's an anti-interferon gamma monoclonal antibody with that complicated name there. There are also trials now for JAK inhibitors and interleukin-8 binding proteins, especially for the macrophage activations. So just a little diagram of the treatment. It's usually an 8-week cycle. So starting with your dexamethasone and how you give it. So it's high dose, the chemotherapy, how that is given, and then the follow-ups. So just at the bottom, the supportive care, which is quite important, is PPIs while on steroids, prophylaxis for opportunistic infections, fungal prophylaxis. In your autoimmune associated, you can try IV immunoglobulins and just to defer live vaccinations while on therapy. So this diagram again just shows the different pathways involved in the secretion of these cytokines, and more to highlight that all these pathways have now become targets for therapy. So the JAK2 inhibitors to prevent the release of interleukin-2. So if you go through the diagram, the different cells involved in the stimulation of the inflammatory response, there are different points of therapy that we are experimenting with. Prognosis: untreated median survival is dismal. With malignancy associated, it's also very, very poor, of 10% in 5 years. So the problem with HLH is that because it's so rare, because it presents with a diverse set of symptoms and it's quite complex, it often results in a delayed diagnosis and therefore a higher mortality. They are saying that after COVID-19 and the cytokine storms and all of the rest, there is an increased awareness. So people are thinking about it more, which is what we want. To keep in mind, it is rare, but it is fatal. And early diagnosis and treatment, it is critical, but it's not even enough for you to save your patient. This is how severe and how significant this inflammatory response is with HLH. So very important to identify, to have a high index of suspicion with those 3 Fs, to make an early diagnosis and to initiate therapy as soon as you possibly can. Hopefully that will be enough. Thank you.
Wow. I think thank you so much, Teruschka. I think this is probably the reason why Wednesday is so exciting to come and listen to these talks. And I think we always learn something new. I trust that we the training, but I think since then I've really never looked at it and forgotten every small thing about it. But it's reality, I mean, when you look at what happened in COVID storm, and you look about some patients that we see in critical care with the PCT of more than thousands. And I think because, in medicine, you only treat what you know. Your knowledge is so much myopic And unfortunately, actually, sometimes we're not aware that we don't know enough. And I think for me, this just highlights that kind of case that perhaps we're missing quite a lot. And that maybe awake in that sense that we need to start collaborating quite a lot, especially, I mean, I don't think any physician could just actually have that discussion of pulmonologists. But I think because of the collaboration between the clinicians and obviously the you guys who are really based in the labs. And I think obviously I think there's quite a lot to learn from each other. And I think for me today, obviously we're going to be looking quite a lot. And I think, and one of the things that does this syndrome have to do with anything to do with the activation of your dams and pumps? I mean, damage at the associated molecular pattern or your or your
Yes.
pathogen associated, which means bacteria in dead cells. Can they play any roles in activation, or do you have to be anything?
No. It's not pure. So in children, it's purely genetic.
Anything.
But in adults, it's all these other
So you have to
ways
do something else.
has to do.
So they have to be triggers.
So the triggers usually, most commonly infection, malignancies, and then of that, mainly heme malignancies. But infections, especially viral and especially EBV and CMV. EBV more commonly so, and important to identify because they respond to antiviral. I mean, obviously you've got to do the immune suppression, but then they also, if you can clear the virus, sometimes you will ultimately need something like rituximab, something for that. They can do very well. So it is important to clear this underlying
The actual come first. The end chicken. Do you think the virals come first? CMV can be reactivated. These can be reactivated. EBV can be reactivated. So the question, which one comes first? Reactivation or acute infection? Or maybe the syndrome first and then?
I would say the infection because the syndrome would present earlier. You would have quite an ill patient at the beginning, and then so for me it makes more sense to have the viral infection first, and then you develop your severe symptoms and present with that. Could be the other way, but
And the role of steroids?
well,
I said because they can
very that is one of the mainstays of treatment is very high dose steroid treatment. If there's neurological, then it's also intrathecal steroids. So definitely it's the mainstay of treatment.
And you didn't mention about the toll-like receptors. Is there any particular kind of toll-like receptor that get activated? Because I know there are bacteria that respond bacteria, fungal, and also for tumors. Is there any particular kind of?
We didn't specify which toll-like receptor. It was more a generalized thing. I suppose if we go into the target on this diagram, sort of the targeted therapeutic options, we probably find more because it's one of the. It's one of the
and most of them are really quite based on the nuclear capability kind of activations.
Yeah, NFT.
Not like two receptors.
So these are all the targets, but yes, if you can identify the underlying trigger to treat that, I mean, it's unlikely that you're going to now cure his hematological malignancy overnight, but if there's therapy to be initiated, it can be. If there's antiviral therapy to be initiated, it can be in conjunction with treating this hyperinflammation.
So perhaps I think the right thing then we start your antiviral actually earlier. Once you have your those biomarker in fever, your therapy, that's very common.
So they recommend as part of your workup to do the viral PCRs. Yeah, not just.
But you could also start on a cycle. Your CMV might take 24 to 48 hours, depends where you're practicing. It can be purple, perhaps take longer. It can in an area, it's perhaps quicker.
Yes.
So they're really good too.
Yeah. So I think what they are also saying is try and identify it as soon as possible because it can be so catastrophic. Don't wait for your more specialized tests to come back before you treat it. Have that high index of suspicion and treat sooner rather than later, and treat whatever you can. So if you can identify the underlying, try and treat it in addition to treating the inflammatory response that you get with steroids and suppression.
What's the reason for the hypertriglyceridemia?
Yeah,
Why do
really
they
interesting.
why
Yes,
do
I
they
agree.
get high triglycerides during this whole process? There's other things you can kind of explain, but I don't know what is the reason for the triglycerides.
It could be because of the liver dysfunction that you get.
Because in that patient of yours as well with the acute pancreatitis, I mean, high triglycerides can also give you
Yes.
pancreatitis.
No,
So,
absolutely. So
But-
with that one, because of the borderline score as well, Kim, it was difficult to say which is which. Is it not HLH? Is it just the severe reaction from the pancreatitis and things that you presented quite late with that? Or is it now?
But what I got by saying the high triglyceride levels, could it because of this inflammation of your lymphatic system, but that's why it transported spill over, or could be because what would be the mechanism? You know what I mean? That's perhaps the fundamental questions. What actually lead to the high triglyceride levels? Okay.
Any idea, Leon? So does it mean also this hypertriglyceridemia is going to be treated by giving the dexamethasone and other management?
Or the role of statin, or you know what I mean?
So it's not one of the severe things or the pertinent things to treat now. So in any of the articles, nobody has said you need to treat this hypertriglyceridemia. It's not.
So-
It's to dampen the immune response. Mainly, that's your mainstay of treatment.
just especially in that case of yours now, so first of all, the patient is so ill that he's probably on TPN, which is going to increase the triglycerides even further. It's going to be on sedation, probably propofol, which will also give extra. So it is a bit of a tricky situation.
It is.
So,
Yes, and also, low fibrinogen is also one of the criteria, and it is an acute phase
Yes.
reactant as well. So that might increase it to a normal level. So it is very difficult in these cases to.
But I think
That's what
triglycerides
the
is not known to
score
be a acute phase
No,
reactant.
no.
So that's
Not-
I think let's not
not that.
misunderstand that. So the question that I mean, obviously, let's assume the patient got pancreatitis, and if it's quite severe, you could also have, especially somebody with immunocompetent, which you can also have those high level of inflammations, especially when the liver is involved, because ferritin is just a marker of it. Having hepatitis, your ferritin can really shoot quite
Yes.
pretty high.
Yeah.
Yeah. So
That is why it's not so.
I think last year, septic uterus, and then she had many of the features. She had cytopenia, she had a very, very high ferritin, and she did have liver dysfunction and everything. I don't think it's all of this as a diagnosis, but I think it was predominantly sepsis.
Yeah.
And then inevitably you do get steroids. I mean, severe sepsis, and I do actually get it.
I think our next presentation, I did ask Dr. Darren Joseph, a pulmonologist, to actually unpack about the pathophysiology of the steroid. And obviously, we're looking at the steroid, how do they act in the body, in the context of COPD, and also context of sepsis. Where because if you understand the role of steroid, because it's normal that I say it's a double-edged sword.
Yeah.
How it works, and one of them is really, I think, that to deactivate your nuclear kappa B, but also having other effects on it. So
Let's just quickly review that. They say that hypertriglyceridemia is due to a decrease in lipoprotein lipase.
or transport, yeah.
Yes, and then that is caused by the cytokine 2 necrosis alpha that actually decreases that.
Okay.
So it's the lipoprotein lipase decreased activity caused by the cytokine.
So just this case of ours as well. So he didn't have a fever at all. He didn't have any organomegaly. Those two are quite often present. So he didn't have that. And then his cytopenias, I mean, he had an anemia, but he had a thrombocytopenia, but the anemia was not severe enough. So according to the criteria, you need an HB of less than 9 or less. This was 9.6. It's just above. His platelets were very low. So a lot of his things were borderline. So in him, probably, more the inflammation. A secondary from the pancreatitis itself.
My question there is just, what would trigger you to do a bone marrow? Because if you've got such an acutely ill patient, you would think all of this is all sepsis driven and sepsis related. So
they were specifically looking for it because they had that high ferritin, and the reason for the marrow was a suspected HLH. So they were looking for it.
Yes. Again, you diagnose only what you know.
Yeah.
But thank you so much. I think we appreciate it's really quite nice cut age discussion, and I think how much more smarter today than yesterday. Thank you. Yeah, that was nice. Surprising. Really good.